Hello, Cliff. We
Good
are
morning.
ready to go when you are.
Okay, sorry, I'm a little tardy. So first of all, just start off by thanking you all for jumping on this call. This morning in our health system, we had 128 COVID positive patients. The number that were on ventilators this morning is 8. I thought I'd share just so folks have an understanding of what that means for a system like ours. We have about 300 staffed beds at Creighton University Medical Center. It's our largest single facility. And so, today across all 15 of our hospitals, we have a total of 132 patients. That's actually up a little over 40 from last week. So we have continued to see a gradual increase in the number of folks requiring hospitalization. Just for a point of reference, our prior peak was back in the end of April, which at that point we had. So we really now have, set a new record, I guess if you would, in terms of the number of folks requiring hospitalization in our system. Back in July, the end of July 27th, 28th, around that time frame, we were actually down in the 50s. So over the last couple of months, it's been a slow and steady increase to the point where we find ourselves today, this morning, at 128 patients. That's actually 4 less than yesterday morning. So I don't believe that we've plateaued yet. If you look at the infection rates and the hospitalization rates and the test positivity rates, it does appear that we still have another maybe couple of weeks of gradual increasing demand. And when I say demand, I mean demand for hospitalizations by patients that are infected with COVID. So I'll take your questions, but before I do that, just as a reminder, the things that the general public can do for those of us in healthcare is, continue to follow the precautions, pay attention in terms of washing your hands, wearing your mask, avoiding large groups to the best of your ability, because the challenge with this disease is that people do spread the virus either before they're symptomatic, or in some cases they may never become symptomatic, and that makes it even that much harder to control the outbreak of this virus. So I'll stop there, Taylor, and let you tell me whatever the questions are.
Okay, the first question that was pre-submitted is, what's being done to plan for a possible surge?
So there are really 3 things. So first of all is physical capacity that you have to plan for. So in some health systems don't have physical capacity like we do at CHI Health, and so they may be the ones that might be setting up tents or some sort of temporary capacity to handle additional hospitalizations. That's not an issue for us. As I said last week, I think I've said a couple of times now, we today have north of 300, closer to 400 beds that we could, if we had staff and we had patients that needed them, we could actually essentially turn on the lights and use across our 14 hospitals. So, that capacity, physical capacity, always exists for us. And it is what we are now, which is the other thing you have to do in terms of planning for this, is really planning on staff. It's the one thing that we have that is in CHI Health's favor, is that we've got physical capacity. We have made requests, have orders for traveling nurses. These are through these third-party companies, one of which is based here in Omaha. But we've got contracts with now at least 4 different companies that are sourcing additional nursing staff for us, with the idea that while we already have some on the ground, we will continue to ramp up our staffing over the next couple of months, quite frankly, because these contracts tend to be 13-week contracts. And so we'll have these additional staff available to us, and we can then extend them once they're here, should we need them. So physical space, staffing, and then lastly is obviously make sure you have supplies, right? Those are the three components for us that make up the planning for increased hospitalizations that may be in front of us.
So this next question was pre-submitted, and then I'm combining it with one of the questions in the chat, as it's pretty much the same. How does the governor's 10% rule affect CHI Health? Will CHI Health still be able to do elective surgeries under the governor's new DHM?
So we've been working very closely with the state, with the governor's office around the designated health measure to make sure that we understand exactly the intent and then how we might as a health system comply. We've also been working with the other health systems as well, because we're all obviously wanting to be compliant and make sure that we've got the capacity that we might need over the next 3 or 4 weeks. Ceasing or stopping non-urgent procedures is absolutely a tool. I think I said it last week, it's a tool that we've got in our toolbox. I would tell you that over the next couple of weeks, we predict that we may find ourselves in a position where we have to start triaging procedures that are scheduled. Obviously, there are hundreds, if not thousands, of people in our region that have medical questions, medical issues, medical concerns that need to be addressed. So we're absolutely not in favor of just a wholesale, stop everything for the next 2 months, because we know of the negative health impacts that can have on those individuals that may need a biopsy, may think they have cancer, may have some other issue. But we are absolutely prepared to begin to make decisions in a fairly fluid manner on whether or not we've got the adequate staff, adequate capacity to continue to do every non-urgent procedure that we're doing today. So let me reframe that. I would say we're absolutely prepared as of this moment. We don't believe we need to start stopping non-urgent procedures today, but tomorrow could be different. Next Monday could be different. We look at this every day, and quite frankly, more than once a day. Our clinical leadership are making decisions about what we can safely continue to do versus what we should not do from a procedure perspective to make sure that we've got adequate capacity to handle whatever admissions might come our way.
You touched on this a little bit, but let's go more in depth. How are you preparing to handle more patients? Are you looking for outside help from doctors, nurses, staff?
Ultimately, we could need, additional resources in terms of physicians and advanced practice clinicians. I don't believe we're not there yet. Our primary focus at this point is nursing staff, and to be able to have enough nursing staff to open up additional physical capacity that we have, open up rooms that are ready to be used for patient care should we have patients that need them. So that's our primary focus. As I mentioned, we are working with third-party companies to bring in nurses from other parts of the country. As a large national health system, we also have the ability, should we need it, to tap some of our own internal resources from around the country. We haven't pulled that lever just yet, but that is another tool that we have that makes it a little bit different for us as a large health system. I understand that smaller health systems or individual hospitals, it's a different situation they may find themselves in, because they don't have the ability to move resources across communities or even across states like we do. And so that's probably more of a challenge for the smaller health systems and smaller hospitals than it is for us, at this moment.
Are you looking, you also touched on this, so this could be brief. Are you looking to set up temporary clinics to add more beds?
So we are not. We have 150 7 clinic locations across the region. So we've got plenty of clinic capacity for patients that might be ill, that need to be tested, et cetera. And as I mentioned, within our existing facilities today, we have about, almost 400, a little less than 400 rooms that are equipped and ready to go should we need them for patient care. So we don't need a tent hospital.
Are smaller community hospitals prepared to handle a surge, and what are they doing to get ready?
I can't speak for other community hospitals. What I would tell you is there are smaller, both critical access, which are very small community hospitals, as well as even smaller, other smaller community hospitals within our system. And they are absolutely a part of our planning and our preparation. They will have access to not only the supply resources, but also the staffing resources that they need, just like any of our hospitals within CHI Health.
What have you learned from the start of the pandemic to now in treating patients, preparing staff, and having the supplies you need?
Well, let me address supplies first. I would say it's safe to say that we've, most health systems for the last decade or two had really been focused on a just-in-time inventory model to limit the amount of, supplies that we would have on hand on any given day. That's obviously good business practice in a normal sort of steady state. I would tell you that, we have larger supplies of stock of supplies on hand today than we did back in March. That's a direct effect of what we've learned through this pandemic over the last 6 months. So I would say that's one thing that we've learned. I think the other thing, just from a clinical perspective, our physicians have learned how best to care for these patients. There's been collaboration across our national system, particularly amongst our critical care physicians, our infectious disease docs, so that best practices have been shared widely across CommonSpirit. And you're also seeing that really across the medical profession just in general. So I think one of the lasting kind of lessons learned from this pandemic is that there's a lot of wisdom in the larger group, if you will, and in sharing treatment protocols, sharing approaches that seem to really make a difference, even if it's before there's a great, placebo-controlled study to justify it, has helped. So I do believe we've learned a lot about how to what's effective and how to treat patients. I think the other thing that we're continuing to learn is the nature of this virus is such that it's not going away. And I've said before, we've planned for the fact that this may be with us for quote years unquote, not knowing really what's going to happen, whether vaccines are going to blunt the spread of this virus or what other might happen from a clinical perspective. But I think what we've learned is that this virus is challenging just because there's so much spread that seems to occur before people are, sick and ill or symptomatic. And that makes it even more important for us to not let our guards down. I think I'll speak for myself personally. You wake up and you just wish that it would be over, and unfortunately it's not. We need to make sure that we don't let our guards down as individuals, because when we do, that's when the spread seems to show up. And as we're seeing right now in actually most of the country, but in our region in particular, there's quite a few new infections, which are leading to obviously quite a few more hospitalizations than even 6 weeks ago. And that's something that, as much as we don't like it, I think it's a lesson that we just have to learn and not let ourselves forget.
This next question came in ahead of time, and then I'm also combining it with one in the chat. So is CHI Health currently employing traveling nurses, or are they available? And the second part of that question is, have you seen an increase in rates for those nurses?
So yes, we do have traveling nurses in the facilities in our system. You know, if you think back three years ago, most health systems in the country were doing everything they could do to limit the number of travelers they had. We're really focused on recruitment and retention. Now I would say that this is the pandemic has made that flexible workforce model that you can have when you use contingent labor or traveling nurses is, you know, it's been very valuable to us. So yes, we have some already on the ground, some working. We've got additionals on order that are in the queue that have been identified that will be coming over the next couple of weeks. And then we have, you know, additional orders out that would be more for the longer term. And when I say longer term, I'm talking, you know, December, January timeframe that the companies we're working with are sourcing, you know, right now as we speak. And so that is that's a process that not only we are using, but I would say probably every health system in the region is also following, because we do, you know, believe that there's an opportunity for us to need more nurses in the next couple of months. And as I said before, you know, the best problem for us to have would be we'd get these traveling nurses here on the ground and we'd not need them. You know, then for us, that gives our organization opportunity to let our staff take the much needed time off to rest and recharge. And so, you know, that'd be a great problem to have, which would be to have too many nurses based on, you know, not needing them in the next couple of months.
So I think you just answered the question of whether we anticipate hiring more in the near future. You said we have more in the queue. You may have already also touched on this. Have we had any trouble getting the staff that we need? And are we pulling from other CHI hospitals or through Common Spirit?
We're not pulling through Common Spirit yet, although that's all a tool that is available to us. You know, it's not infrequent. I mean, almost every day we move staff between hospitals in the Omaha Metro. I'm not aware of us having, at least at this point, been moving staff amongst other communities, Lincoln, Kearney, Grand Island, either to the Metro or to one of those other communities. But that is also, again, a tool that is available to us. You know, we have a common electronic health record platform now across all of our hospitals, so it makes it even easier for us to move staff from one community to another should we find ourselves in the position of needing to do that. You know, we also are constantly recruiting. So, you know, if you know, you've got a nursing degree and you want to come be part of the CHI Health family, we've got a job for you. We've got new nurses that have been recruited that are coming out of orientation almost all the time. I mean, it's you know, it's an ongoing phenomenon for us to always be recruiting nurses. And so that hasn't stopped and is something that is, you know, part of what we do day in and day out. The one thing that is different recently is that with the governor's assistance through the use of some of the CARES Act dollars, we are able to offer a premium to our own existing workforce, our own existing nurses who want to work some additional shifts. And this is, you know, you can't do this long term. It's a short-term fix in terms of having, you know, existing staff be able to maybe step up and take an extra shift or two a pay period. So that'll also, in the very short term, help increase capacity. The risk of that, obviously, is that you just continue to work people who are already tired. You work them more and more, and so that's not a long-term solution, but it is something that through the assistance of the state and the governor, we are able to do using some of the CARES Act dollars that are available to us.
Is there a connection between strep throat and COVID-19, and can someone be diagnosed with both at the same time?
Great question. I don't know that there's a connection. I don't believe there's any reason why you couldn't be infected with both strep as well as COVID. The test we use for COVID in our system is not the antigen test, which is a bit less sensitive. And so you may have more false positives or false negatives with the antigen test. We use the PCR test, which is more of a genetic test, if you will, for the looking for the virus genetic material. And that is a much more sensitive test than the antigen test. So I think if the question is, could you get a false positive because of strep? I don't know the answer to that, but I would say we're using the most sensitive test to detect COVID that exists, at least as of today.
What advice do you have about strep throat?
You know, I mean, like most infectious diseases, you know, it's not touching your face or your mouth, you know, it's good hand hygiene. It's staying distant from people that, you know, are ill or have ill symptoms. You know, those are the same precautions that basically work for just about every infectious disease. So I would say it's very similar from as far as strep and COVID are concerned.
And then we have time for one more question, and you may have mentioned this at the beginning, Cliff, but we had some people hop on late. Do you have a percentage number for our capacity right now?
Yeah, so this morning, if you looked at all of our capacity, and again, we look at it by hospital, by type of bed. So, you know, by, you know, ICU versus what would be a normal hospital room or a med-surg bed, as we would call it, versus things where you might not think about treating COVID patients like, you know, like a labor and delivery unit, for an example. So we look at that by hospital, by day, and without COVID, our goal is to be at least 90% occupied starting the day. And quite frankly, you know, if we're more than 90% starting the day, that's generally good for us. That's the most efficient use of what are, you know, are very expensive fixed costs. So if you think about hospitals and why we do that, we're similar to like an airline in the sense that, you know, an airplane not full is incredibly costly. And so for us to be maximally efficient, we need to utilize our fixed facility, our fixed capacity, our fixed costs as efficiently as possible. So any given day, we shoot to be at least 90%, preferably 92, 93, 94, 95% occupied to start the day. That's because every day, you know, we'll have anywhere from, you know, at a given facility, you might have 20 discharges to 30, 40 discharges. I think I mentioned last week, just in the Omaha Metro and including Lincoln, you know, we can discharge up to 200 patients on a given day. So every day, even though we might start off with, you know, 95% of our staffed beds occupied, we know that we're going to have at least, you know, 100, if not closer to 200 patients go home, which then frees up beds. So that's why managing capacity in our world is an hour by hour, day by day sort of phenomenon, because it, you know, it changes. And, you know, on any given day, we might have 100 admissions, we might have 200 admissions in that same group of hospitals. And so we just have to be prepared for really all the contingencies. So it's a long way to say we look at our capacity every day. It is typical for us to start a day off at 95% full, you know, down to maybe 90% full. And that's exactly where we find ourselves today. What's got our attention, it's really got everybody's attention, is when you look at the COVID infection test positivity rates, you look at the hospitalization rates, and you can tell that we are seeing more people test positive on a percentage basis. And that generally is the leading indicator to more hospitalizations. And so we're able to say, just like everybody else is, we can expect more people needing to be admitted over the next 2, 3, maybe even into December, you know, over the next 4 or 5 weeks. And so that's what we're preparing for.
Okay, thank you so much, Dr. Robertson. And he will be back next Tuesday around the same time, just like this week. We'll send out that reminder with the Zoom invite and ask that if you can submit your questions ahead of time so we can make sure we get to everybody's questions and combine duplicates. I did want to let you guys know tomorrow we're going to have Dr. Nikhil Jagan. He is a critical care doctor and pulmonologist and led ICU care at CHI Health St. Francis when we saw our first surge back in the spring. So he's going to talk tomorrow on Zoom about what we've learned, treatments that we're finding useful, what we're seeing in terms of patients and trends that we maybe are seeing more of now that we've learned more about the virus. So just like today, you can send your questions ahead of time or type them in the chat, but that will be tomorrow morning, and I'll send a Zoom invite out as well. So thank you, everybody, for your time. Look out for the Zoom recording download link coming to your inbox soon. Thank you, everybody.